Okay, aloha everyone. Welcome. We're just going to do a quick roll call. When I call your name, you can please identify yourself if present. This is for our advisory board members, Amy Thomas, Jeanette Ayers Kawakami. I'm here, present. Giovanna Appo,
Hi, present.
Linda Beechenor. I think she's trying to get logged in here.
I don't see her yet.
Okay. Olivia Kim will be absent. Sarah Kamakaviva Ole.
Here, thank you.
Great, thanks, Sarah. Sandra Leiji Brandon. Did I pronounce that wrong?
Sandra
Oh,
is
she
not
will be
here
late.
yet.
She will be late, sorry.
Okay.
Tammy Napoleon.
Present.
Hi, Tammy. And then Clementina Syria Ulep. And Lillinois Kabiko Akiona. Okay. Not seeing them here. We will now roll call for our HSCN staff, the Laura Reichart, our director.
Present.
Oh, thanks. Carrie Oliveira,
Present.
Leanne Hussey, Amy Ono,
Present.
and Brianne Kuwabara.
Present.
Wonderful. Okay, so now we will be approving the minutes.
We don't yet have quorum, so let me call Linda and see if we can, if I can support her. Or Bree, can you address Linda's concern? She's saying that she does not have a sign-in. Alternately, we can ask her to sign in with a regular public member and then promote her to a panelist.
She is communicating with you on
Text that she does not have a passcode. Maybe it's not as functional as we had hoped. Oh, the passcode. I see it. Okay. Provided it to her.
Apologies to everyone while we wait for quorum. We just need one more member so we can get started soon.
Hi, we should have Linda in the attendee group. If we can promote her, then we should be good to go.
I'm not having any luck with promoting Linda
Okay, can you make
to
me the chair,
panelist.
please? Or can you make me a host, please? Sorry, everyone. It's a new process for us.
It's okay, technology.
Okay, perfect. Promote to panelist. There's a little bit of a delay, and then she'll be joining us as a panelist. There, we got her. Ta-da! All right, we should be able to call in Linda to the roll call.
Yay. Okay, so finishing roll call, we have Linda Beechnor. If you
Here.
could. Thank you.
Thank you.
Yay. All right. Wonderful. Okay. So the minutes of the previous meeting have been distributed. Are there any corrections? Okay, if there are no further corrections, the minutes stand approved as distributed. And yeah, happy Nurses Week, everyone. I completely
This
forgot.
week, yes.
It's going by so fast. Okay, so to ensure we conduct our business efficiently and provide everyone a fair opportunity to be heard, we will follow these procedures. Testimony timing, you will have an opportunity to speak when specific agenda items are called for deliberation or action. Identification, for the record, please state your name and any organization you represent. Regarding time limits, in accordance with board policy, oral testimony is limited to 5 minutes per testifier per agenda item. And the visual option under Act 12, all remote testifiers have the option to be seen on camera while providing testimony. Upon indicating you have testimony on an agenda item, HSCN will move you from the audience to a panel position for the testimony and will return you to the audience position at the end of your testimony. Connectivity. Please be aware that if we lose our audio-visual connection to the public broadcast, we will recess. And if it is not restored within 30 minutes, the meeting will be terminated and rescheduled. Public record. All testimony, whether oral or written, is considered public information and will be posted on the board's website for public inspection. And finally, we appreciate your cooperation in maintaining a respectful environment. The board reserves the right to remove any individual who willfully disrupts these proceedings. Okay, so starting with our first agenda item, we have HSCN program updates and strategic initiatives. So we have these updates. We will receive updates from staff first and then ask for public testimony, followed by public testimony, then board discussion. And first up is Leanne Hussey.
Hi, everyone. Thank you for having me. My name is Leanne Hussey, and I'm the program manager for nursing professional development. I have been with the Center for Nursing since 2011. I started as a nursing student, and I've worked here in part-time positions and full-time positions under various programs. And during COVID, when we were all working from home, Laura and I and Carrie and I would have conversations about what my role entailed and where I wanted to grow professionally. And Laura proposed that the theme nursing professional development kind of umbrellaed all of my smaller projects that I was working on. And leaning into this new role as the program manager for nursing professional development allowed me to create long-term goals and strategies that were more cohesive for all of these smaller initiatives I was working on. Well, let's see. So most of my initiatives fall under our mandate, best practices and quality outcomes. This lovely heliconia image comes from our 2025-2029 strategic plans, and you'll see it a few times throughout my presentation. I feel that the projects that I work on address all three of these aspirations, as we call them, not just the middle nursing professional development one, but leadership development and enhanced nursing education as well. So the center is a CNE provider. As a CNA provider, we offer nurses professional development opportunities. Our learning activities cover topics that address leadership development and clinical and academic faculty education as well. We are an ANCC accredited CNE provider. In 2025, we offered 27 courses and awarded over 2,000 contact hours. RNs took our courses 590 times, while APRNs took them 103 times. We also focused on partnering with the community to broaden the offerings, the topics and offerings that we had. And we had partners that included UH Manoa School of Nursing, UH Cancer Center, Oncology Nurses Society, and the Hawaiʻi State Coalition Against Domestic Violence. We are also excited to announce, I don't know if any of you are familiar with our current CNE catalog, is very old looking. So we're excited to announce that pretty soon we will be launching our catalog upgrade. The goal for this version is to more closely align with our website and our branding, as well as increase usability and make it more user-friendly. So we'll announce when it's officially released, but we hope it'll be within the next month or so. Our evidence-based practice program. So we not only provide that as a professional development arm for nurses, but we have EVP workshops that are specific to leaders for leadership development and educators. We continue to facilitate collaboration between academic and practice partners on EVP strategies and initiatives. In November of 2025, we held a workshop to roll out the new 2025 Johns Hopkins tools to our partners across the state. This was open to both academic and clinical nurse educators or any staff nurse or nurse leader who was interested. 47 nurses attended, and expert faculty from Johns Hopkins walked them through the EVP process using hand washing as a common topic and reviewed all of the new 2025 tools. Another initiative that we have going on is our statewide EVP initiative on the topic of nurse hydration. We have 4 participating organizations and are currently in our dissemination phase. So all 4 organizations came together, focused on nurse hydration, did a literature search, synthesized, came up with pilot plans for each of their individual organizations, and piloted and collected their own data. And then we came back together at the end of that and found the common themes. So as I said, we're currently disseminating the findings from that project. We presented at the 2026 Hawaiʻi Nursing Scientific Symposium. We just did a CNE webinar on our CNE platform, and we submitted an abstract to the 2026 Johns Hopkins EVP conference. We're also planning to write a manuscript on this initiative. As far as we know, it's the first one in the nation. We don't know of any other states who have tried to do something like this. Faculty development. So our faculty development program focuses on enhancing nursing education by ensuring that our faculty are well prepared and feel well supported in their role. We provide nursing professional development opportunities to faculty that include leadership development. So again, hitting all three of our aspiration arms. We receive $27,000 annually in general funds to address clinical faculty training needs for all 8 schools in schools of nursing in Hawaii. We release the funds on a first come, first served basis. We partner with national organizations to ensure that we're providing sound education from beginning, intermediate, and expert level prep courses for clinical faculty. And also we offer courses specifically related to simulation education. This year was the first year we provided the opportunity for faculty to apply for funding for conferences, trainings, workshops that they found on their own if they were interested, and for ones that we don't currently offer. So we're happy, I think, to announce that funding through FY 2026-2027 has been allocated, and so our next open cycle will be in 27-28. So other ongoing opportunities for clinical faculty training that we have is the Western State Simulation Alliance repository of simulation scenarios. All schools of nursing across the state have access to this. They also have access to Nurse Tim, which is on-demand faculty development for part-time and full-time faculty as well as graduate students. We are working to provide the new 2025 online on-demand Johns Hopkins learning modules to faculty members. Their learning suite includes a 5-hour course that covers the entire EBP process and 2 shorter courses that focus on searching the literature and specifically on their 2025 tools. Again, these are all funded from that $27,000 that I had discussed earlier. So if any of our faculty are on here and want to take advantage of it, please let us know. We also do continue to convene the Hawaiʻi State Simulation Collaborative. As I had said, we joined WSSA this year. So benefits to joining the Western State Simulation Alliance is the ability to collaborate with simulation educators across the West Coast. It gives us opportunity for faculty development and support for simulation certification. It provides shared resources like the simulation scenario repository that I mentioned earlier, and it provides us financial savings on simulation courses that are offered through the WSSA. Locally, our Hawaiʻi State Simulation Collaborative goal currently is to take the scenarios from WSSA and make them culturally relevant to our schools and our students and our patient population here in Hawaii. As we develop those, we'll also develop a repository to house those for our local partners. And the last part of my job, professional conferences. So the center, mainly me, enjoys in-person event planning. And so we do host a variety of conferences that address nursing professional development, leadership development, and faculty development. One of which is the Hawaii Nursing Scientific Symposium. It is a collaborative effort between our Associate Director of Workforce Research, Carrie Oliveira, and myself. We were sitting in my office one day thinking how awesome it would be if nurses could share their research, EVP, and QI work across organizations. And so in 2024, we held our inaugural symposium with 73 attendees. And this year in February, we held the second symposium. It had 136 attendees, and it featured 18 podium presentations and 14 scientific posters. So at the request of our academic partners, we also added in awards so that their work could be recognized when they applied for things like tenure. We would appreciate it if you would save the date for our 2027 symposium. It will be held on February 19th of next year. And our plan is to increase capacity to 175 to 200 participants. Last and finally, we are also hosting the Nurse Practitioner Week conference here in Hawaii. Please save the date for November 13th, 2026. This is being done in collaboration with our local AAMP chapter. We are trying to provide an opportunity to celebrate our NPs, give them time to network, and have them share strategies for improving patient care. So we're bringing out Valerie J. Fuller. She is the president of AANP National, and she will be our keynote speaker. So if you folks are interested in that as well. That's kind of our professional development arm.
And we have questions reserved for after Bree. So I'll just invite Jeanette to welcome Bree, and then we'll do questions for this whole section at the end.
Okay, thank you, Leanne. That's really wonderful news. Thank you for sharing. Next is Brianne Kuwabara, who will be sharing with us.
Okay. 1 second, folks. Oh. One second while I try to reclaim host privileges. Or someone can allow me to share who has them.
Bree, it says that you have it. I think,
Try
Leanne,
now,
you have
Bree.
to relinquish it. Yeah.
Yeah, I've managed to reclaim it. Okay. Aloha, everyone. Thank you for giving me an opportunity to talk about our programs. Many of you are already familiar with the Hawaii Clinical Placement Collaborative. Ultimately, the Clinical Placement Collaborative falls under our mandates for recruitment and retention. And I also believe that it helps to support improving nursing education. Any improvements we make to the capacity to support students for their clinical education definitely increases the pipeline and helps to support the pipeline of students into the workforce. The Hawaii Clinical Placement Collaborative has been going since 2011, and we've got, well, since 2016, and we've got a big group of wonderful people that all work really well together in a very constricted environment. So we are essentially, for our urban areas, particularly for Oahu, we are very saturated. So we tend to keep a very close eye on what's happening in our clinical placement environment because the trends can be quite telling. We learned that our collaborative helped to support the capacity to maintain student nurses in education all through COVID. And we also discovered that because we have this collaborative in the state of Hawaii, we felt a smaller impact due to COVID than the national average. So we did better because we all play well in the sandbox and we all support this effort. So going over, I don't want to get into the nitty-gritty of all of the wonderful things over all of the course of time that we have done, but a brief update on what kind of trends we're seeing now. And I also encourage you, if you're interested in the Hawaii Clinical Placement Collaborative, we have lots of briefs and reports that are available on our website that you can dig down into anytime. Carrie also provides a lot of meaningful resource data about students as part of the standard research that she does. So I encourage you to drill down in that as well. Ultimately, we have our core partner capacity. And when we talk about core partners, we're talking about what we consider our participating partners, meaning they all pay to play, essentially. They all have access to the same clinical software. We all follow the same procedures on very strict timelines in order to be able to facilitate clinical education in this very constricted environment. It helps to improve operational practices on our clinical partners by reducing some of the human resource burden. It also provides a significant improvement because we have access to data and we now have the capacity to see trends. Overall, when you look at kind of what we're seeing across multiple years, on this very first slide, if you could note that total cohort hours since 2017 have only gained a very small amount. But if we compare cohort hours for the academic year 25-26 to the prior year, we see a significant decline in the total cohort hours. That's really telling. I can't tell you just yet what all factors relate to that, but I can say that one of the things we might note is that we have a higher reliance at some of our schools on utilizing simulation than we have in the past. Our schools typically don't use a significant portion of simulation, so that helps to potentially reduce the overall burden on our clinical facilities. Hopefully, what it doesn't mean is that we're reducing our enrollments. And when we compare that data to the data that's collected by Carrie, we can see that our enrollments compared to this mechanism are relatively stable. So what we're seeing with this decline is some kind of change in our environment about how we're doing our clinical placements, because we're still meeting our needs. One way or another, we always meet our needs, but the way that we're providing clinical placements is changing. Overall, just high level, since the course of time, we have managed to facilitate a significant portion of clinical placements. Clinical rotations, we have 22,682 clinical rotations supported by the collaborative since 2017, and that's totaling over 2 million hours of clinical education. That's a lot happening in our state. Overall, we can see that our hours have peaked during that the 24-25 year, and we see a decline in 25-26. I can say, looking at the 26-27 data, which I only have one academic period for, it looks like we're increasing that number again. So we'll see next year when we start the new academic period, and we're also managing clinical placements and requesting clinical placements, we should start to have some information to compare if this is going to be a significant and repeated decline or not. Ultimately, we can see that we are changing some of our activities when we talk about the distribution of clinical placement trends. So when we look at hours by semester, and we also look at the distribution by day type, we can see that there are some trends that are happening. 25-26, we're not seeing a lot of utilization of both weekday and weekend, but we are seeing a slight increase in the utilization of weekends, which is really good to see. Overall, when we're looking at the distribution of our clinical education hours over the semesters, we see that for 25-26, we have a larger portion in spring and a larger portion in fall than we had in the prior year. So we're not relying as much on that summer semester as we actually anticipated. We were hoping to see for this 25-26 academic year a big change in that, because it's something that our schools have really been evaluating, how they deliver those courses. We do have some schools that are still in the process of readjusting the delivery, and we should see that come out next year, and a higher reliance on the summer semester. Faculty burden. Let's talk about the things that everybody really wants to discuss. So when we look at faculty burden, we really need to be cognizant of the fact that our educators, in addition to our preceptors at our clinical facilities and our unit nurses, our floor nurses, are all really burnt out. It's just kind of a continuation of what we've all been experiencing since COVID. What we are seeing is, over the period of time in the state of Hawaii, we have seen a decline in the average number of students per cohort. What we are seeing is a slight increase in 25-26 from the prior year, which is really good. And I know that we're dealing in small amounts, but it's really important to look at those percentage points because they do matter in the scheme overall. We're looking at how we're also utilizing the clinical placements by weeks. So when we talk about burden, we're talking about work weeks. And I wanted this time to kind of delve into whether or not there were changes in the duration of clinical placements, because that also puts an additional burden on our clinical faculty. And what we can see is that we have declined from work week hours from 2017 and 2018, and we went through some slight declines again from 2020 to 2024, but we're seeing that number rise again. The work week actually does matter because it identifies some kind of stability in the environment in how our clinical educators are working, and also the capacity that we have at our clinical facilities to provide that education for longer periods of time. We hope to see this number increase, but generally looking at national trends, we can say that we are above the national average in terms of our size, our faculty to student ratio, which is typically 6 right now as a national average by most sources that I'm finding. Nobody really is able to reach or attain that 8 or 10. And over the course of years, as much as we have also talked about the safety ratios and staffing ratios, we also have a lot of research related to clinical placement ratios and where that sweet spot is. And most research suggests that it's actually around 6. Overall, we can see when we look at our burden across each individual program type, we can see that we have lots of changes in the way that we're delivering, or the students that we are delivering these activities to. It's important to note for APRN, DNP, and MSN that they don't necessarily represent the largest picture, because not all of our schools aggressively utilize the Clinical Placement Collaborative for attaining those clinical placements. But what we can see over time, we've had a precipitous drop in LPNs, but it's also important to know that Maui, who is working aggressively to improve those numbers, has not been a partner of Clinical Placement Collaborative for many recent years. So we're also expecting to see that number go up, and we're really excited about the capacity to continue to build and to help support those activities. Specialty capacity. This is the high demand and high difficulty. Instead of looking at all things that we're doing across all types of clinical placement potentials, it's important to know that we are maxed out on OB, we are maxed out on PEDS, and we are maxed out on behavioral health. And those are areas where we really need to work to find creative ways to have these clinical placement opportunities, whether it be looking at alternative clinical sites or looking at a completely different view of how these are being delivered, because we simply don't have the capacity to really grow that in our current healthcare environment. But it is something everyone needs. And it is something that we also spend a large amount of human resources on the academic side every year, trying to make sure that these specific areas are met. They are high demand, high difficulty. We've had that problem. It continues to be a problem. And what we really need to see is the most aggressive utilization as possible in order to be able to grow our student body. So we can't really add more students to any of our programs unless we can make sure that we can cover these really difficult areas for clinical placements. We have a lot of schools that are working on finding lots of really creative ways to provide this clinical education. But the simple fact is we have to make a concerted effort to grow this before we can grow our student body. Overall, as the major takeaways, we are seeing cohort capacity decline. We are underutilizing, and we have fragmented scheduling. We have rotation duration at 8.3 weeks and an increased workload for our faculty. So that's also operational pressure when we think about it's a workload for faculty, but it's also a workload for the nurses that are working alongside faculty. We're looking at reducing the reliances on any kind of one specific program, stabilizing summer utilization, expanding targeted off-shift placements, increasing multi-day cohort models would be something that would make a significant impact to the way that we're operating. And in 2026, 2027, we have big projects that we're working on that were sidelined for a long time. We have subcommittees that are set up to look at streamlining the requirements management, which will significantly help the burden on our academic side in the amount of work that they have to do to onboard their students. We're looking at any way to be able to do that, whether it's standardizing documentation, standardizing processes across all of our clinical facilities that are partners, and also looking at finding tools to be able to help facilitate that. In addition, we have a sub-project also looking at the potential of integrating allied health into our clinical placement collaborative so that we can also support allied health placements, whether it's something that we're supporting directly or helping our clinical facilities support, should be something we are able to tell you in next fall, because hopefully we will have gotten down to a point where we have all of the details of the complexities of allied health so that we can make a formal plan about how we can support them for the future. And that's all I have.
Thank you, Brianne. That was great. I do see that we have a few extra advisory board members. I just wanted to identify them and confirm their presence. We have Clementina Syria Ula.
Thank you, Jeanette. We had a Manoa Awards ceremony, so that's why I'm late. Thank you.
Okay, no problem. Thank you, Clem. And we have Amy Ono. Is that correct?
Amy Thomas.
Amy Thomas. I'm sorry. Amy Thomas. Make that note here. Is Amy here?
Yes, present. Thank you.
Amy. Great, thank you. Okay, I apologize. I know we're running a little behind because of the technical difficulties we had earlier. But we would like to go ahead at this time to open the call for any public testimony. You can raise your hand, use the raise hand function to be recognized and state your name for the record, and each person will have a maximum of 5 minutes per agenda item. Okay.
I see no hands raised, Jeanette.
I don't see any hands either. Thank you. Okay. At this time, I will ask the advisory board members to have any open discussion on this matter. A discussion regarding these program activities presented.
We do currently have a hand raised.
Oh,
Rosalie has her hand raised.
apologized. Hi, Rosalie. Thank you.
Would you like to be seen, Rosalie?
I'm going to promote to panelists so she can, and then Clem's after Rose provides her comment, then we can move back to board discussion.
Yes.
Rose has been promoted to panelist. Rose, if you can unmute. Yeah, there you go.
Can you hear me?
Yeah.
Hello?
You sound good.
So I wanted to speak upon the preceptorship talk. I thought that was a very enlightening. I really not interested, especially when we start talking about ratios and how that the instructor with students, and we feel pain, like as a person, a lot of the businesses, we've addressed it a lot at the bargaining table, making preceptors, trying to get, because we understand it, like we see the network, it goes to senior or new nurses, and and I heard burnout, and there is a lot of that at the bedside, and I heard that
Did your audio go out for
Rosalie,
everybody hear
you're
Rose?
currently stuck a little bit.
We all want. And, whatever we can do to help support that, if whatever programs, but know that that is something the nurses have addressed at the bedside in terms of preceptorship. It's a lot of work. I know there has to be a lot of support. So I just wanted to put it up there that I really glad that it is being addressed with this past presentation. So whatever, especially you need, let me know if we do any programs or anything in the future. That would be great. Anything we can do to support that.
Thank you.
Okay, thank you, Rose. Clem, you had your hand raised. Did you still
Yeah,
want?
so in terms of the faculty burden under clinical placement trend takeaways, I was interested about the underutilization of summer and fragmented scheduling. So, Bree, in those areas like OB, PEDS, psych mental health, perhaps, would I be correct in, thinking that if we utilize more summer scheduling, would that help?
It absolutely would help. What we're finding is that, essentially ultimately we can only grow as much as we can grow. And these are areas where all of our students have a touch point too. And it's one of the areas that has historically been constricted. COVID made it worse. And these areas are the ones that have not recovered after COVID. And what we're seeing, part of that is higher acuity in these settings. For mental health, the burdens and the issues are very different. We have lost some clinical sites. We had clinical sites that that some schools were not sending students to for some period of time because they felt like it was unsafe. And so we're relying on really creative ways to fill the behavioral health placements, and most of those are in our community. But when we look at OB and PEDS, those are ones that are almost impossible to find in the community. We have ways to do PEDS in unconventional. We can do that in an outpatient setting and still get kind of the same clinical experience. But we do need to find creative ways. And the only way to really expand that is to utilize off shift time, off prime shift. So instead of days, we need to look at ways and that also creates more faculty burden. It creates more faculty cost to have individuals that are working in evenings and individuals that are working on weekends. That costs the schools more to be able to support. So that is definitely a concern. And then, yes, moving to summer utilization for all of those areas is a way in which we could potentially increase. So, the only gaps that we really have right now until we build those new partners or build some creative ways is to really focus on using those gaps. And those gaps are summer and off-peak hours.
And I see that Linda's hand is up next.
Thank you, Bree.
Hi, Linda. You wanted to share something?
Yes, I was just trying to unmute. It's my understanding that this is our discussion about the retention and recruitment programs that the center is currently running. And I just wanted to comment, first of all, that we've agreed that we're not only addressing workforce numbers at the center, but also the environment in which nurses practice. And I was wondering if there's plans to move forward with identifying the problems in the workplace for the center to address and how we might work on that. And my suggestion is using the data from the wonderful license renewal survey from 2025, Carrie, to mine for those issues and find out what more we can learn about nurses, for example, who are planning to leave the profession and why. So my comments are directed at what in the future we're going to be doing around recruitment and retention, which I believe is this part of the discussion.
Linda, thank you. I'll just note that in a future agenda item, we do have a section called Future Agenda Items and Planning Discussion. And part of that is to discuss emerging strategies and issues. So this section is program updates and on our existing strategic initiatives. So I'll just recommend that we have entertained that discussion at that later agenda item.
I just wanted to confirm that this was where those programs would be discussed. Because we've just talked about students and faculty here, not anything about recruitment and retention.
Right. No, these are updates on our program, the program updates and strategic initiatives.
Right.
Yeah. So you are correct that the recruitment and retention program is the Clinical Placement Collaborative is a program under our recruitment and retention initiative. But since you're talking about an emerging issues, I think that it's more germane for that later item.
Thank you.
Yeah. Just as an agenda item conversation.
Thank you.
Okay, thank you, Linda, for your testimony. At this time, we can have the advisory board members open discussion.
Jeanette,
Yeah.
we currently have someone also with our hand raised, and so
my hands aren't showing up here for some reason.
Allison Kaneshiro has her hand raised, and I'm going to see if I can't promote her to a panelist to make her visible if she chooses to.
Okay, great. Thanks so much, Bri. I'm sorry about that, Allison.
Hello, Allison. You should be able to unmute.
Okay. Oh, I see now. All right. Hi, I'm Allison Kaneshiro. I'm a nurse practitioner. It was a long time ago that I was a student for my bachelor's degree. But, what I heard was there's 6 nursing students per cohort. And I know that back in 1989, 90, when I was in clinicals, we had 8 to 12 students in our cohort for each clinical rotation. And I did a lot of night shift and evening shift clinicals because that's when they had spots at the different hospitals that I went to for my clinicals. So I think that, in my opinion, I think having those different times for clinicals, and also maybe increasing, maybe 12's too many in OB, but maybe it's not too many in med surge versus, like if I was doing an ICU rotation, then maybe 4 would be a cohort for that type of situation. So I think that just having 6 across the board for every clinical rotation maybe is one of the issues that of getting people through their rotations.
Thank you, Allison.
Amy, would you like to respond to that? Or?
I was just gonna ask the question because it's my understanding at some of the sites or many of the sites and with the clinical rotations that it's 6 on the unit at a time, but the cohorts can be anywhere from 6 to 10 in size, but just 6 on the unit and maybe 2 are in simulation or doing another experience. And so I just wanted to clarify if that's accurate, or do you know that information as well, Bri? Thank you.
I do. I don't have a slide that's representative of that at this time. Those things typically kind of at a more granular level come out in the reports that we provide and the briefs. I can say we're very, very, very lucky to have some of our clinical partners that provide the opportunity to do what we call split rotations, which is exactly and we can call them novel because they're not the standard way in which we do clinical placements. But we have found a way to be able to educate more students by that model that you're talking about, where those student groups are rotating. So we have a fewer students on the floor at any given time, and they're either being educated by their clinical faculty or they're engaging in simulation during that period of time. That is one way in which we are meeting the needs, particularly in OB and PEDS. But not all of our clinical sites allow that model to exist, and that where it does exist, it makes a huge impact. But where we don't have the capacity to do that with some of our clinical partners that have OB or PEDS rotations, is it would be really advantageous if we could get that model going everywhere.
Thank you. And I'm going to note that we're moving beyond our agenda time frame, well beyond our agenda time frame for this, so we can adjust our schedule in the future to allow for more time. But I'm just going to urge us to move on to our next agenda. And then, Jeanette, I do want to recognize that Sandra was just able to join us.
Okay, great. Thank you, Sandra. Okay, so moving on to our next agenda item. Laura will be leading this discussion for HCR 105, HD1, SD1.
Yep, thank you so much. Thank you for that meaningful and deep discussion over the last section. We have discussed this resolution at our last meeting. I just want to recognize for the group we had discussed recusals, particularly because of past in the last meeting, particularly because there was a mention about having advisory board members advise on the report writing for this resolution. And because of that, we were trying to entertain how to engage in our very dynamic board, particularly because many people have potential conflicts of interest, and we have to navigate that for both offensive information practices, so who oversees sunshine laws, as well as state ethics. So it's a tricky, and we talked about this last meeting, it's a tricky dynamic because everybody, or most people, not everybody, but most people who are on the board are nurses. And so we do have this allowance and this recognition from the state that even though you're a nurse, that doesn't provide a conflict of interest. So I'm just going to say that because here we don't have to have that conversation. We're having a discussion, but no vote. And then that's one of the critical factors. And we were talking about the potential of a vote. We don't need a permitted interaction group, which is the permitted subcommittee, because of the changes in our resolution. So all of that to say, the resolution looks like it will pass the Senate and the House. So we have amendments that were made by the House as well as the Senate. Importantly, so the House HD1 removed quite a bit of language. It changed this report from being a dashboard to a repository, which I feel is more favorable because a dashboard would be quite limiting in the information that we can provide, whereas a repository allows us to provide the resources, or if it's behind a paywall, a link to the resources. So it becomes a better public resource, in my opinion. And then the second thing is that it changed the language from only asking for ratios, which is just a number, to also the strategies in addition to the ratios. And I had the opportunity to convene or connect with American Academy of Critical Care Nurses, AACN, and they said, you know, if an organization does all 6 of our first 6 recommendations, they will have achieved the 7th, which is the singular ratio recommendation. So it really, they really felt like the strategies are as important as the ratios, and I feel like it's a nice thing through these amendments that we were able to include both. And then finally, there was questions I had asked, you know, is this only for, if you read the bill that preceded the resolution, it was very clearly for hospitals and registered nurses. The Center for Nursing, we support nurses across all settings and across all roles. So I asked that clarification. You know, and to the comments earlier about faculty as well. What is the scope of this work? Is it just hospital RNs? Is it all RNs? Is it all licensure within nursing? Is it all settings? So there are some clarifying scope questions. The report has changed to still registered nurses, but it has changed to all settings and subsettings. So I ask, and if we can, I don't know if you can click on the Senate Health link if you're able to, Bree. But if we look at the public testimony that I had provided at this earlier date in April, there is the starting work that I have provided, which is going through the national organizations that I have been able to find. It's beyond what was initially in the resolution, trying to find that full scope of professional organizations that we want to include in that report. They did clarify that we do not need to provide state law or international law, which I think is helpful because laws and professional organizations have different methodology. The basis and the implications are different. But if you are able to go, and we don't necessarily have to do it at this moment in time if it's difficult to go to the link now. Oh, there we are. And if you go to the table at the end of, yeah, there we go. So we've started to list the organizations. So this would be the basis of that repository. And I've been able to find if it's in a paywall, so that we'll have to think of a creative resource to support public access. If they have a ratio or a strategy, and then also the source. So this is the format that I'm thinking we'll use for the repository. And I just wanted to open it up to discussion if you have any recommendations. The second part, I just want to note the timeline. The report is due December 20th. About December 20th, it's 20 days before the legislative session. The legislative session will start January 20th of 2027. So if we're going by calendar days, that's December 30th. If we're going by work days, it's December 23rd. But because this report, we also has to go through the UH approval process. That's the standard process for resolutions. I'm hoping to get the report over the summer. So any feedback that I can receive now would be very helpful. We want to make sure that we have an inclusive and well-representative list of organizations that we have in this report.
Okay, thank you, Laura. At this time, I'd like to open the call for public testimony. You can use the raise hand function again to be recognized. I don't think I see any hands raised.
We have two hands that are raised. We have Rosalie and Letitia Callis, and I am promoting both of them to panelist.
Okay, thank you. I apologize. I don't know why it's not showing up on my end.
Okay, it looks like they are both able to speak. I will let you call on whom to start.
Okay. Rose, would you like to go ahead and get started?
Sure. Well, I appreciate all this. This is very important to myself and the group that I represent. And I just wanted to give a little bit more on the bill in terms of, yes, it was focused on the hospitals because we wanted to start somewhere small, start somewhere and build out. We do recognize long-term care facilities if that's what it'd be great to have that. It'd be a good starting point to have it here if that's what we're looking at. Dialysis as well. That's a very hard subject. Lots of issues in that areas as well. So I just want it to be known that, it's not just a number, not to me, not to the people that I represent. We do look at other areas, and I'm glad any type of strategy that will, help us to alleviate the stress and the burnout at the bedside would be very welcomed. And we are here to support that, just as I think when I heard for the facilities for our university, it's eye-opening. But I think this is the root is at the bedside. So I think this is great. And if you need help, we're more than happy to help, on a subcommittee, give you more than enough information because we've been doing a lot of research on it as well. So Thank you very much for looking after this. This means a lot to the nurses, that there's support from the Hawaiʻi State Center for Nursing regarding this. It will mean a lot to us. Thank you.
Okay, great. Thank you, Rose, for your testimony. I believe, Letitia, did you have your hand raised as well? Did you want to share something?
Yes, please. Thank
Okay.
you.
Thank
My name is Leticia Calles, and thank you, board, for this opportunity. I think it's very important to connect the evidence-based practice to the recommendations that professional organizations are recommending, as well as regulatory agencies such as the Joint Commission has now recognized the importance of safe staffing. One thing I would like to add is I noticed on some of the outline here, some of the previous references were from years past, such as the MedSurg organization, and those actual recommendations are more up to date. The MedSurg organization, for example, now actually recommends ratios. So I think just like any evidence-based practice, it should be within 3 years for the recommendations that we're sharing. Thank you.
Leticia, I sourced those from the direct website. So if you have more recent links, I'll reach out to you and see if I can, if you can help me find those.
Okay, thank you so much.
Thank you. I appreciate that comment.
Okay, thank you.
We do have another hand raised, Jeanette.
Thank you, Bree. I'm not seeing it.
Okay, Allison Kaneshiro has her hand up. I am promoting her to panelist.
Thank you. And thank you, Allison. You can go ahead whenever you're ready.
Okay. All right. So I'm just a little bit confused. I see that this spreadsheet, are you going to be giving just this information, or are you going to be giving recommendations for rewriting of the bill? Is this it? You're just giving them this and then they got to figure it out? Or how is this work?
The process yes, thank you. The process for a resolution is the items of the report are provided by the legislature. So the response is to what is requested in the legislature, or by the legislature, excuse me.
So you're just going to give them this information and then they have to figure it out? Because I think that's the problem. I think every time we do a little study, and then then the legislature, those folks, they just don't understand it because they're not medical people. There's not one nurse or one medical person there in the legislature to understand like this stuff, so like I feel like it's just another opportunity. Maybe there should be some kind of other information there besides just, oh, this is what these organizations feel is the best for staffing ratios. But it's not really all about ratios. It's about acuity. It's about safe practice. It's about making sure that they understand that, without having a work environment that nurses feel like they can do the patient care that is going to benefit the patient, that it's going to end up failing again in through the legislature, and it's never going to get resolved. And that's my concern, is that what are we doing? How is this really supporting the nurses who are dying out there in the hospital, who want to do a better job caring for these patients, but can't because they just don't have the time, because they are so overwhelmed with what they're doing. And we have nurses that are leaving because it's unsafe to practice, and it's not worth putting your license on the line every time you go into work because you don't know what you're walking into. It's just frustrating.
Hey, Laura, may I? Allison, thanks so much. My name's Sarah Kamakvivole. I'm one of the advisory board members And I was specifically tapped to the board regarding health policy. I really appreciate your comments and your feedback, and I think a lot of folks on the board and in the staff have similar, have felt and have observed and heard similar feedback from the nursing community. So I just want to say thank you for reiterating those comments. That's really important for the staff and Laura and her folks to be able to go back to the legislature every year and say, we're not just trying to make things hard. We really are hearing this feedback directly from nursing community across the state. That there's ups and downs to every bill and every resolution. So I just want to assure you the resolution is kind of Laura and her folks, this is just fulfilling what's called the resolve clauses of the resolution. And those are kind of the parts of the reso that say like, okay, now someone has to do something. And so this document that's being shared in my interpretation is how Laura and her staff are fulfilling what they anticipate will be demanded of them should the resolution pass this session. I don't think by any means it's the only thing that's being worked on. I think that the staff are doing a great job hearing loud and clear what folks want, and I just want to reassure you that I know it can be really frustrating to see a resolution that feels like it doesn't have teeth, but the anticipation that the reso is going to pass, I think it's great that the staff are working to make sure that they can basically get it stamped, signed, sealed, and delivered out to folks as soon as possible so that they can go back to their essential functions, which are indeed, I think, addressing some of the frustrations that you've shared. And there's always, the ledge is going to close this week, but there's always the off season. I think that there's always more that can be done, and I really think that folks are working really hard on the long arc of trying to address some of these concerns. So just thank you for your feedback, and I just want to tell you this resolutions, dozens of resos pass every year. It's really hard to get any kind of teeth into them. And I think folks are Laura and her staff, frankly, I think do a really, really good job at keeping up with the ledge among government units that I've experienced. And I'm sure if there are specific thoughts or ideas that they would be open to hearing from you about how they can better represent your interests. Thank you.
Thank you, Sarah, and thank you everyone for your testimony. At this time, I will ask the advisory board members to have open discussion on this matter. And you can use your raise hand function. And if I don't see it, Bree will help me.
Oh, Linda's hand is up.
Oh, I can see Linda's hand. Thank you, Linda.
I guess you can only see panelist hands. There it goes. I just wanted to thank Laura for getting on this before weeks ago you started this, and we really appreciated seeing the progress that was coming along with it. And I'll save further remarks for the future part of our agenda. But thank you for putting this together. It's looking great.
Okay, any other comments? If none, thank you for this discussion. We'll move on to our next agenda item, where we will be discussing the healthcare landscape and workforce trends, which I will hand the discussion back to you again, Laura.
Okay. Thank you. And this may also be, I just want to recognize this may also be an item that is relevant to Linda's earlier questions as well related to recruitment or retention. But I just want to provide an opportunity for the board to have a discussion. And there's two big public conversations, and I know we have some members here. So I just want to recognize that the request for conversation here is about how to direct Hawaiʻi State Center for Nursing strategy development in relation to these big initiatives. So not necessarily asking for people to talk about their own organizational positions if there is any potential conflict of interest. That said, there's some really big conversations at the forefront, and I think it's worthwhile. We have a lot of large insurance changes, including the very public HMSA, the proposed HMSA and HPH vertical integration, but we've also heard about other insurance changes in our landscape. We're hearing about the Hawaii Island healthcare expansion, which all of the big changes and plans didn't really make it into our workforce projections. It wouldn't be captured in the data we have, but we know that it's relevant. And there's going to be large increases in facility, or there will be facility growth, and therefore changes to the workforce strategies needed to meet the recruitment and retention demands. And then to Linda's point about overall recruitment and retention. So I want to start the conversation because we do plan our lengthier strategic plans and kind of like course correcting our strategic priorities year after year in the fall, but that means that we have to prepare for it. So I wanted to just provide open discussion at this time, but give the context that, there's things that we know are on our horizon, and we need to make sure that we are incorporating what we think might be coming up in the horizon into our strategic plans. And having that conversation now is very important. So with that, I will pass it over to comments and for discussion.
Okay, thank you, Laura. So this will be the open call for public testimony. You can use your raise hand and Bree can transfer you to a panelist position. And I believe then I will be able to see.
I have one individual. I have Allison Kaneshiro who has her hand raised. I am promoting her to panelist so she can engage.
Okay, great. Thank you, Allison. You can go ahead whenever you're ready.
Okay, thanks for having me again. So when we talk about recruitment and retention, I kind of looked over some of the workforce and what our workforce is, and we have very few young people in our workforce, and we're just getting older and older, and we're all going to retire, and then who's going to be left? Like, I feel like that's like a huge issue, and that's part of that retention and recruitment. And I really feel like even when we talk about the nursing schools and the staffing ratios and like all of these things, I think that it's not just one thing. I think they all tie in together, because how are we going to retain and recruit more people if we can't get them educated? How are we going to, you know what I mean? So, and if the working conditions are so bad that people are leaving the bedside and going on to other careers outside of nursing, how are we going to keep them? So I think it's all tied together. And I think that part of that, your strategic planning and response to changes and this retention and recruitment, it has to be tied back to the other issues that we already have talked about and discussed and have issues with, and so on and so forth. So that's just my only comment.
Thank you, Allison.
Okay, thank you, Allison. Any other comments?
I see one, another hand raised. Rosalie has her hand raised. I am promoting her to panelist so she can engage.
Okay, thank you, Bree. And thank you, Rosalie, go ahead whenever you're ready.
Again, this is hi again. Regarding the strategic planning and response to changes, I think it's really important, there is burnout in those areas as well, like Hawaii, the Big Island, the North Hawaii group. I mean, those are hospitals I know of, and you know, they're strapped, stretched thin. What we can do to support them, I don't know what that would look like. Could we understand more Like when you talk about alignment and planning, is about getting them support or setting programs up. I know we talked about it at the last meeting regarding education was, trying to fill in the holes, getting more people there for support, growing, the locals to become the healthcare force there. But we should also address, why is the burnout all the way around? Um, that's something I keep bringing up in other areas because we talk about getting the students and everything like that, but just kind of like Allison's been saying, the big meat of the problem and the biggest thing you'll hear is it's at the bedside now. What can we do to solve it with the present working force? So um, whatever we can do to support that and help out, let us know.
Okay, thank you.
Thank you.
All right, thank you everyone for your testimonies.
We have one more, Ali.
Okay.
Oh, Ali, sorry.
Promoting to panelist, so Ali or Ali can engage.
Okay, thank you.
Hi,
Anything
can you hear me?
Yes, thank you.
I work at the bedside and I have to agree, I do hear that we don't have very many young nurses, but it's because they're leaving. And I know that we do have to grow the recruitment part or like the training part, but right now I think the focus has to be more on the retention because we're also losing people who will be training all these new nurses. And I like at work, almost on a daily basis, somebody will tell me that they're looking for another job or they're looking for other opportunities. So I think it's going to become even more critical that we really need to focus on recruitment.
Thank you, Ali. I see Allison has raised her hand as well.
Thank you, Ali. And
I'm promoting Allison to panelist.
go ahead, Allison, when you're ready.
So I put it in the chat, but I just wanted to mention that I know that the local high schools all have, not all of them, but a lot of them do have programs that are geared towards, um, the science programs that are geared towards healthcare. And so, is there a way to include that as part of the strategic planning by using that as a way to, help support the needs here in Hawaii for people to become nurses and so on and so forth. My husband teaches anatomy and physiology at one of the high schools, and I know that they have a program that is really geared towards teaching, classes that are geared towards healthcare to kind of help prepare them for a career in healthcare. And so, is that something that would be helpful for your strategic planning, partnering?
Thank you, Allison.
Thank you. Are there any other? Oh, I see, Clem, you have your hand raised. Go ahead.
We
Thank you,
can move
Jeanette.
to, if we
In
move,
terms- Okay.
sorry, we'll just move to the board member discussion then, if that's okay, Jeanette, just for time.
Yes, yeah, we'll go ahead and have
Okay.
the board on this agenda item, the healthcare landscape and workforce trends. Oh, did you want to go ahead
Oh,
or something? Or
yeah.
Linda? Or sorry.
Linda has her hand raised.
Oh, Linda. Hi, Linda. Go
Oh,
ahead.
I'm sorry, I thought Clem was going first. She had her hand.
Yeah, thank you. I think that Hawaii Pacific Health actually has a program that they just started last year called the AHI, that responds to what some of us are talking about. So maybe Amy is very much a part of that. If you could give us more information about the AHI program.
Sure. And to Allison's comment, yes, absolutely. Agree. We could definitely continue more of our strategic planning in the high schools. Currently, Hawaii Pacific Health, we are in about 17 of our high schools doing our medication or medical assistant and CA training programs. But the Academy for Healthcare Innovation is an independent school that was started for some of these types of pipelines to build pathways into nursing through certified nursing assistant programs, medical assistant programs, surgical technology, surgical instrument processing. Those are where those programs have started. That all information about those programs, because this isn't just for Hawaii Pacific Health, it's actually for the entire state. And it is an independent school that was stood up for the benefit of workforce pathways across the state and really to elevate career paths for not for high school students specifically, but for anyone above age 18. So those pathways are there, sort of the pre community college pathways, and then of course pathways into hopefully Clem into the University of Hawaii at Manoa for the nursing programs and other nursing programs as well. So the website for that is ahihawaii.org. So AHI Hawaii.org, where there's a lot of information about those programs. But I really like where this conversation is going in terms of the strategy starting way upstream. So thank you.
Okay, thank you, Linda. Do you want to go ahead and with
Oh,
your
yes, I wanted to thank all the nurses who came to give testimony today, to take the time to come and have dialogue directly with all of us at the advisory board. And I wanted to reiterate something that I heard earlier. How does the center see the report that's coming from the Reso as a guide for legislators to regulate safe patient staffing? Because that's what we were hearing in the hearings, that this resolution was a way to guide the legislators in their thinking and their understanding of what the issues are. So I think I'm putting the question out there to this group. Thank you.
If you give me one moment, I have to help one of my small people for a moment. To your response, I think looking to the body of work that the legislature has asked first, I believe it was in 2024, they asked the Legislative Reference Bureau to do a review of quite a number of to report on quite a number of topics, including state regulation, and they have done a very wonderful job. And so if you're looking at the body of work, there's that. What it didn't do comprehensively is address the nurse staffing recommendations. As a commenter earlier said, some of them are very emerging. Some of them have been updated recently. And so having an updated body of research, or not research, having an updated body of what the national professional organizations recommend and the variances is important. I'll note that there is some complexity to it. For instance, A1's report is 144 pages and has 14 pages of tables. So consolidating that into a digestible and consumable content for a legislator, I think it's still it's a far leap there. We don't have healthcare professionals in our elected offices. And so there is still interpretation that needs to be done by them, but having these multiple bodies of work, I think, will be beneficial. And this is quite, if I can just do a landscaping review quickly, many organizations didn't have any recommendations prior to 2022. At the Center for Nursing, we looked for them when we started doing our wellness as a factor of recruitment and retention work. Nationally, there's also a call for professional organizations to opine on what safe staffing would be. It was very embraced, and then that there needed to be time for them to develop. And when you look at the body of work from some of these organizations, you can see that they are still developing their opinions as well, and they are looking to see if there is a body of evidence that it can support that work. Sometimes there is not, and so they're pulling from, for instance, pediatrics said, well, we don't have a good body of research, but we can look to adult medicine science and see what adult nursing science and apply some while there is that gap in research. And so I think it's also really relevant to look at that whole landscaping review and the implications that each of these professional organizations are addressing. Or identifying, not addressing, sorry.
Okay, thank you, Laura, and thank you everyone for that discussion. I know we are short on time here, but we do next have a brief discussion for our future agenda items and planning. Laura will share again.
Thank you so much. I know we're right at the tail end and we've had a deep discussion already. We do, as I mentioned, have our larger, what we call our strategic planning meeting in the fall. Normally we address either professional development for the board or engage in some strategic visioning. We do have our 2025 to 2029 strategic plans, and so all that work would fit within these strategic plans. And so the thought was, because we did the big strategic planning this past year, to provide some board development so that we're very equipped to, or that you all are equipped to advise us and you feel well prepared and supported in your role. So some recommendations or some, just kind of brainstorming. If you see anything here, board governance, organizational culture, conflict resolution, other thoughts, for instance, navigating diverse perspectives, what kind of content do you think would help you in your role as an advisory board member, so we can work over the summer to find either guest speakers or content that can support your development and your support to us. And then we have brought in expert facilitation, as I mentioned, and then we also tend to have it as an in-person meeting, and so thinking about what kind of venue would best suit that. And that's all subject to purchasing policy. So we will be fiscally responsible. So if there's any discussion or recommendations, if you want to provide a comment by email, please don't reply. I'll just reply to me, so we're not engaging in that serial communication.
Okay, thank you, Laura, for that reminder. At this time, we'll go ahead and open the call for public testimony. You can use your raise hand function to be recognized, and Bree will add you into our room.
I'm seeing none.
Okay, great. At this time, we'll ask the advisory board members to have any open discussion on this matter. If you want to raise your hand. If not, I believe we will be.
We have Linda.
Oh, hi, Linda. Sorry.
I just wanted to ensure that what we discussed about earlier that was tagged as future ideas moves forward in this part of the agenda.
Yeah. Yes, we will take all of this feedback into consideration. Thank you so much for checking.
Thank you.
Okay.
Can I comment and respond to Linda?
Oh, sure. Yes, Carrie, thanks.
I have the outline of a report related to retention of nurses from the workforce survey. I'm working on that as we speak, so I'm going to separately address retention of new grads from the incumbent workforce in response to the comments that you all have made over multiple meetings. The intention is to discuss variation in retention and reasons for the intention to leave the position, the employer and/or workforce by setting, age, and county, as well as provide a discussion on the difference between attrition from practice and relocation. So like moving around within the workforce. To contextualize, departures from a position is not necessarily attrition from the workforce, right? That leaving a position or employer is not the same thing as leaving the workforce. And then also there's an open-ended question on the survey that asked about what can your employer do to facilitate improving your workforce? And we're going to put a summary of the responses to that. So, FYI.
Perfect. Thank you, Carrie.
Awesome. That's great. Thanks, Carrie. Okay, it looks like we are coming to the close of our meeting. And we will share a few of our upcoming events. Looks like we have our HSCN CNE activities and a national event, the National Forum of State Nursing Workforce. Their annual conference on June 22nd to the 24th in Minneapolis, Minnesota. Tammy Napoleon will be our advisory board representative. Thank you, Tammy. That sounds like a lot of fun. And Laura and Carrie will be our HSCN staff presenting. Also, that sounds like it's going to be great. At this time, we will like to open. Oh, and also we have the HSCN CNE live events coming up. 2020 for 2026. We have upcoming in July 16th and November 12th, the APRN Learning Series, as well as the Nursing Policy Series, May 21st, August 6th, and October 16th. Sorry. Is that correct? Dates? Sorry,
15th.
15th,
October
sorry.
15th, yeah.
Let me increase the brightness on my screen. Okay, and those are our upcoming activities. Okay, now our next meeting is scheduled for the 15th of August. This is our professional development strategic plan topic, the third Saturday in August. And we have, oh, sorry, did you say something more?
No.
Oh, okay, sorry, I thought I heard something.
No, I think it was just a muffle from someone else.
Okay. And we'll have call for any public testimony. Okay.
I'm seeing none.
Okay, no hands are raised. We will move on and ask the advisory board members to have open discussion on this matter, any of these updates and upcoming events. Okay, no hands raised. Okay, it looks like we've met the end of our agenda. Can I have a motion to adjourn the meeting?
So moved.
Okay, thank you, Sarah. And can I have a second?
I'll second. This is Linda.
Thank you, Linda. Is everyone in favor? Aye.
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 All right, that was great. Any opposed? No, okay. Only 4 minutes behind schedule. Okay, if no opposition, then we will adjourn this meeting at 5:34.
Thank you.
Thanks, everyone.
Thank you. Thanks, everyone. Have a great evening. And we'll see you next time.